Hi, everyone. I'm Ivy Elkins, one of the co-founders of the EGFR Resistors Lung Cancer Patient Group. And I am here with one of my co-founders, Joe Feldman, and with Dr. Stephen Liu, because we just held our 5th annual EGFR Resistors Research Summit last week. It was held on November 2nd and 3rd in Chicago. In case you aren't familiar with the EGFR Resistors Research Summits, this is the 5th year that we've brought together young investigators from across America who are doing work related to EGFR positive lung cancer. As in the past, we had a fantastic group of mentor judges, actually 8 of them, who are leaders in lung cancer, chaired by Dr. Zofia Piotrowska, who gave feedback on the young investigator presentations. This year, we were fortunate to have 15 young investigators from diverse locations across the country attend the summit. 9 of these researchers were trainees and 6 were junior faculty. In addition to getting experience in presenting their work at the summit, these researchers truly benefit from the development of relationships, collaborative relationships between themselves and the mentor judges. 3 of us patient advocates, myself, Joe Feldman, and Diane Legg, also attended the summit and interacted with the young investigators. This is incredibly exciting since these investigators are truly the future of research. We, the EGFR Resistors, started the Research Summit back in 2019. That was our first summit. And when we created it, the hope was that developing these relationships and the sense of community through bringing people together would really encourage our young investigators to stay in touch and work together and continue their work in lung cancer, especially in EGFR lung cancer. Our first summit in 2019 was in person, and we had to pivot to virtual formats for 2020 and 2021. But we tried to keep them as fun as possible with matching screensavers and, some fun swag. Last year, we were able to go back to an in-person summit, and we held this year's summit in person as well. So although we made the virtual summits as interactive as possible, it was really nice to be in the same room all together because that provided so many opportunities for informal discussions and, more collaborative discussions, both through small table meetups that we had and just, casual conversations at meals and breaks. Next, I'm going to turn the speaker focus over to Dr. Stephen Liu, one of our mentor judges, and he'll talk about the research and award winners from the summit.
Thanks, Ivy. Thanks, Jill. Always a pleasure to be involved with this summit and really see some of the wonderful work and really the rising stars in thoracic oncology, getting a chance to meet them early on. It's such a rewarding experience. We had some really wonderful presentations. In addition to just learning about their research, I think it's great to give these trainees and junior faculty a chance to present in front of a group of their peers and to answer questions. I think it's a really valuable experience. And I got to tell you, from our side on the mentor and judge role, we learned a lot too. And it really is a great experience all around. Our day started with the trainee presentations. And the first one we saw was from Dr. Allison Chang at Massachusetts General Hospital. She presented results from the ASCENT trial. That was a phase 2 study of induction or consolidation of afatinib, a second-generation EGFR kinase inhibitor with chemoradiation plus or minus surgery for stage 3 EGFR mutant non-small cell lung cancer. This was a relatively small study that actually closed early due to slow accrual. But I think an important lesson here is whenever we run a trial, sometimes the landscape shifts a little bit. And here, afatinib, which was a very promising drug early on, it did have a little bit more toxicity than our third generation drug, osimertinib. And really, osimertinib in this setting is being studied in the LAURA trial, which has completed enrollment, and we hope to hear about soon. But it rendered this study a little less relevant. The study closed, but we still learn from these trials. So even trials that do not complete, even trials that are negative, need to be reported. I think it's important to the patients that participated, but also to us as a community. We learn a lot about the tolerability here and here. In this trial, some patients did elect to go on to surgery, and we learned a lot from those specimens about, what is this persistent population that is still there after afatinib treatment, and how are those cells surviving that can really better inform future combination treatment. So this was very well presented trial update from Dr. Chang. Then from Georgetown University, one of my colleagues, Dr. Brinda Gupta, a fellow at Georgetown, presented a case with concurrent EGFR and MET exon 14 driver mutations within a single case. This was not an acquired MET alteration, but really something present at the beginning. And we were taught years ago that these driver alterations like EGFR and ALK and KRAS, they exist really in a mutually exclusive state at diagnosis, but we're learning that it's not always so simple. And while generally that is the case, very rarely we can see these early on. It's really important we understand if that's happening, because it may influence the types of treatments we pursue. And so assuming that all of these cells have the same driver, while that is generally the case, not always. And so if something's not responding as we think it really is important for us to recognize that and to investigate why that's the case. And so this is a very interesting case. Another case from Dr. Amanda Herman at the University of California, San Diego, looked at a HER2 exon 20 insertion. Now, this was an acquired event, but why this is relevant is we now have an FDA-approved agent to target HER2 exon 20 insertion on small cell lung cancer, and that's an antibody-drug conjugate called trastuzumab deruxtecan that was, in fact, delivered here. We had a very nice discussion about how to approach acquired resistance, including whether or not it's relevant to continue the original TKI, the original targeted agent that introduces more toxicity. We had a really interesting scientific discussion between Dr. Zosia Piotrowska, Dr. John Haymock, and Dr. Herman, who fielded those questions, I think, very well. So really great dynamic discussion. And then another training presentation was from Dr. Eric Gardner, who's at Weill Cornell Medicine in New York City. He talked about the role of RB1 loss in histologic transformation of adenocarcinoma to small cell lung cancer. This was a very elegant design, a lot of preclinical translational science, and this presentation stood out just for how well this complex mouse model work was presented. In fact, some of our judges went out of their way to compliment Dr. Gardner on the clarity of his slides and how you can take something that's really complex translational medicine and boil it down to essential, understandable presentation slides. And he did a very good job with that. Ivy, when we think of histologic transformation, here we looked at a specific gene and its role in the transformation from adenocarcinoma to small cell lung cancer. Histologic transformation, we know, is an acquired resistance mechanism for a lot of our targeted kinase inhibitors. Is this, you think, under-recognized, or are people aware of histologic transformation and the importance of it?
It's really becoming more and more of an important issue in our EGFR lung cancer community, and it kind of underscores how important it is for a patient who experiences progression to be rebiopsied. If you're rebiopsied and you just have a liquid biopsy, it isn't going to show up, necessarily that you have developed small cell lung cancer. So you need to make sure that you're communicating with your healthcare team and pushing for tissue biopsies as well if nothing is found in the liquid biopsy, because the tissue biopsy is, where they can determine this type of transformation. And as people, more and more people are on osimertinib first line, and more people are living longer with lung cancer, we really are seeing a lot more of, this type of transformation occurring.
Yeah, it's a great point. It probably is underdiagnosed. And Jill, when we think of rebiopsy at the time of progression to look for histologic transformation, that's an invasive procedure, requires a little more coordinating. There are more risks involved. Liquid biopsy, a blood test, very easy to do. And I worry that some of our oncology colleagues, some physicians, might make the assumption that a patient would not want to have a biopsy. But what's your experience been in terms of whether patients are receptive to having an extra biopsy, acknowledging the risk, but also acknowledging the importance?
I
Yeah,
think
that's the point that, a lot of times patients will not have the option to be rebiopsied, and their, clinician might assume that they don't want it. I think the key here is within our community, people come to our community to really get educated about what best practices are. And so if they understand why the biopsy is important, and that the information would help guide their next treatment, then absolutely, if feasible and not dangerous, they absolutely will get rebiopsied. For those out there who aren't a part of our group, of course, we're always trying to educate and get word out there as well. But at the end of the day, we tell our group that if a liquid biopsy can provide a lot of information, but it cannot tell you the histology of the cancer. And so it's always good especially if the progression is aggressive, definitely get a tissue biopsy.
I think that that's something that is, again, probably not done enough, and it's important that we not make assumptions on our patients' preferences. So that is something that's important to discuss at the time of progression. Continuing with some of our trainee presentations, we saw Dr. Kevin Levine from the University of Washington, Fred Hutchinson Cancer Center, describe a very complex event. This was a case that had been presented years ago, but an important update. And this looked at EGFR kinase domain duplications, KDD. These are very rare events, but it's hard for us to say how rare because a lot of the testing that we do will miss these. These are in-frame, in-tandem duplications that will often lead to intra-molecular dimerization and a clear dependency on EGFR, but some testing methods will not find them. And we know now from this case and others that when kinase domain duplications in EGFR are present, that cell is dependent on EGFR signaling and can respond very well to osimertinib. This was a case where a patient was on targeted therapy for decades. Had this been missed, the patient would have received the wrong therapy, probably an immunotherapy-based treatment that likely wouldn't have worked. This was detected by Dr. Levine and his colleagues. Patient has received targeted therapy, decades of treatment, really a great testament to how important it is to find these events. Dr. Marie Dreyer presented a case looking at amivantamab in an EGFR fusion. So again, when we think of EGFR, we think of our common sensitizing alterations like deletions in exon 19 and the point mutation L858R in exon 21. There's a wide range of EGFR alterations, and we're getting more awareness of things like exon 20 insertions. But even outside of specific mutations, kinase domain duplications and EGFR fusions or chromosomal rearrangements, these are also driver events that we can effectively target. Dr. Dreyer presented a case looking at an EGFR fusion, non-small cell lung cancer. This patient received a medicine called amivantamab, a bispecific antibody targeting EGFR, and met with a good response. We're going to move that into a phase 2 trial to really demonstrate the efficacy of this approach, also including MET fusions, these rare events. But EGFR signaling is more than just these common mutations. There are a lot of different alterations that could potentially be targeted. And so Dr. Marie Dreyer from Northwestern University outlined this case, presented this phase 2 trial. And so this we think will be one to watch. And from Massachusetts General, Dr. Mary Boulanger presented work that she had performed at Johns Hopkins with Dr. Joy Feliciano, looking at survivorship and the association of unmet needs with quality of life and financial toxicity. This was some survey work that really highlighted how stressful and how much of an impact these unmet needs have on quality of life. Ivy, when we think of survivorship, are we as a group paying enough attention to this?
Yeah, Dr. Boulanger made a really good point. Survivorship truly starts from the moment someone is diagnosed with lung cancer. Sometimes, survivorship is thought of more in the oncology world as when someone's done with treatment and moving on. But for, many people like us who are living long-term with lung cancer, the concept of survivorship ongoing while you're on treatment and medication and, all the things that accompany that, financial toxicity, time burdens, other things are, not necessarily, historically haven't necessarily been studied that much. But, I mentioned earlier, people are living longer, treatments are getting better, and it's becoming more and more of an important thing to look at because the toxicity related to ongoing treatments over long periods of time is real. And if, we study this, then, we can do something to help people who are experiencing it. So I was very, very pleased to see this area of research represented at the summit.
Yeah, as was I. And I think, the EGFR Resistor Summit, it's not just translational medicine. There are lots of different things, lots of different ways to make positive contributions. This was a beautifully presented work, really highlighting an important area of research, and hope those efforts continue. Dr. Ali Shahid from Henry Ford Cancer Institute presented a case looking at some atypical alterations, the EGFR L833V and H835L mutation in non-small cell lung cancer. Again, outlining the importance that there's more than just the common sensitizing EGFR alterations. And when we find these less common EGFR mutations, it's important that the oncologists understand sort of the implications of this, because while a use of a drug like osimertinib, for example, might be off-label for one of these unusual atypical EGFR mutants, and while this specific compound mutation, there's not a lot of clinical data in the literature to support it, we know based on the science under this that this is a cancer that generally would not respond well to immunotherapy, and that targeting the EGFR pathway is predicted to be effective, and in this case was. And so we really need to pay close attention to these reports. We can't just read the headlines and skim the highlights. The oncologist really needs to look at the detail, not just what was there, but what wasn't there, looking at all the things found, not just the front page news. We really need to dig pretty deep to really understand these reports. And closing out our trainee presentation, Dr. Shipra Maheshwari from University of Virginia presented work that she had done there looking at reflex in-house next generation sequencing. And this is a theme, a topic that's really in the mainstream here. How can we accelerate testing? How can we get these EGFR tests done quickly, reported quickly, to minimize the delay in starting effective therapy while still doing it in a responsible way? We don't want an automatic test to be performed and then no one sees the results. And so it's important that the tests are done, but also that they are acted upon and recognized by both the patient and the physician. Very impressive trainee presentation to start the 2023 EGFR Resistors Research Summit. Jill, when you look at these trainees, I was very impressed, not just by the work that they've done, but their composure in presenting these data and answering questions from an at times intimidating mentor panel. Were you just as impressed?
Absolutely just as impressed. And I was going to say, it's very intimidating to have key opinion leaders asking you these difficult questions, and they all held, their poise and answered it in a way that they were confident and said they didn't know if they didn't know. But I was also very impressed with the actual projects that they are doing. They're innovative projects. They're really looking at the challenges and unmet needs of the people in our community community right now. And so seeing that type of research being done and their interest in really, cracking whatever the situation is to understand better and hopefully develop better strategies for treatment is promising. And so future is bright for lung cancer researchers, the trainees, that's for sure.
Indeed. And Ivy, in addition to sort of these trainees presenting their work, getting a chance to answer questions in a room of peers, intimidating at times, but friendly always. In addition, we also had these small group sessions where we got to really talk and connect with a lot of these trainees. You and I were in some of the same small groups together. And, I think that's a really valuable experience for everyone involved, right?
I think so too. It was really a nice, opportunity in a more relaxed setting to ask questions and just talk about, concerns that you might have. I think we had 3 of them at different points take place during the day, the full day of the workshop. And they were nice breaks for everyone to be able to kind of sit down, whether it was over a meal or not, and talk about things that might that might impact their career, get advice from some of the mentor judges, etc. Talk about patient advocacy with myself and the other patient advocates. So I think it was a very nice, less formal opportunity.
Yeah, really nice part of the summit are those interactions and the chance to get to know and welcome sort of new colleagues to the field. Second half of the summit, we saw research presentations from our junior faculty, and these were just as impressive. We started with Dr. Alvaro Quintanal Villalonga from Memorial Sloan Kettering, who talked at RB pathway inactivation. We heard about that from Dr. Gardner about small cell transformation, but this was looking at RB inactivation as a driver of transformation from adenocarcinoma to squamous lung cancer. This was beautifully presented, some wonderful diagrams. He had worked with Dr. Helena Yu and others. And one of the things that really stood out here was that when they predict the behavior based on signaling, these squamous behaving cells, which are largely refractory, some of the more common treatments we would use, those were often missed histologically. And while we want to do tissue biopsy, it also is a reminder that our biopsies are also imperfect, and we need to improve that technology, not just on how the cells under the microscope are appearing, how they're behaving. And when we think of microscopy and just sort of looking at appearance, it's still a relatively crude measure. We need to get a little more sophisticated. And if this work is any sign, where we're getting a lot closer to that in terms of understanding these different behaviors. Dr. Lova Sun from the University of Pennsylvania presented characteristics of long-term survivors with EGFR mutant non-small cell lung cancer. Now, this was the pre-osimertinib era, but why this is relevant when we look at some patients who receive TKIs, while we have an average or a median time on treatment, we know it's a very wide range. And if we look at people that do exceptionally well, people that can stay on treatment for a decade, are there some characteristics that allow us to predict that up front? Because maybe those are situations where we don't need to use these more aggressive combinations up front, where targeted therapy alone it offers the best balance of long-term efficacy and toxicity, whereas those that are not expected to get those long-term benefits, maybe that's where we should really explore these more aggressive combinations. And those are questions that remain unanswered and deserve their own studies. But as a starting point, better understanding who responds longer is a very important part of this. And Dr. Sun really expertly presenting a lot of these data. This was work done through the Atomic Consortium led by Dr. Ross Camage. We saw from Columbia University junior faculty Dr. Benjamin Hersberg present work looking at ATR inhibitors that target osimertinib resistance in EGFR mutant non-small cell lung cancer. And this I thought was particularly interesting. Jill, when we think of acquired resistance, someone's receiving osimertinib, at the time of resistance, we biopsy, we see MET amplification, and we can add a MET inhibitor, like in the INSIGHT 2 trial. We look at someone with developing a RET fusion, maybe we can add a RET inhibitor. And so a lot of that is sort of reacting to the alterations that we see, targeting mechanisms of resistance when possible. Dr. Hersberg's work was a little different strategy, though. And rather than target that specific mechanism of resistance, this was more targeting the process of resistance, really trying to understand how cells develop resistance and really target that process instead of waiting until we see resistance and then adding a treatment, really trying to target the process of resistance and prevent those from occurring. And that's a little different, but maybe even more important, right?
Yeah, I think it's very important, more important because we're being proactive instead of reactive. The current paradigm for treatment is reactive. We know that, all of us are going to at some point develop acquired resistance. And so we're waiting to see what is causing it, and before we go on to the next treatment. And the reality is, a lot of the time, maybe most of the time, there isn't necessarily another approved targeted therapy to treat that resistance. So if we can upfront understand the process and, kind of intercept it when it's happening with, different strategies, then that can allow patients to, well, hopefully we can prevent it, but either prevent it or prolong it, and allow patients to be on the first line therapy for much longer. But I really think too that there's a lot of information that he is looking at on the biology of this process, and that could provide us with some insights into really the future of how we treat, with first line therapy.
This was really great work, and this could be a new paradigm for us. I think the implications, if we can really effectively understand, how resistance is occurring, target that effectively, it extends beyond just EGFR. Even this could be something that has widespread implications. And in addition, because we're not trying to really, induce cytotoxicity with these ATR inhibitors, maybe the dose is going to be a little different, a bit lower, more tolerable. So I really am excited about this work, very early stages, but very promising principles. Not traveling too far from Rush University, Dr. Kusha Pedari presented some work on the concomitant use of CYP3A4 inhibitors. Dr. Pedari has a background in pharmacology, and he was looking at inhibitors and inducers and reported outcomes. Concomitant medications, even things like marijuana, these can have impacts on the metabolism of medications. They can influence the amount of drug, maybe the efficacy and the toxicity. These are important, but maybe we don't pay enough attention to what the other medications are. Often a patient might have multiple physicians prescribing medications in addition to an oncologist, a primary care physician, maybe changing medicines, especially over the counters. So I think that we probably we don't do as good a job as we should collecting that information in clinic. Ivy, is this, do you think, a universal truth? Is this something that we could all do a better job at?
Oh, definitely. I mean, every over-the-counter medication that a patient takes isn't necessarily reported back to their oncologist. And, I mean, the oncologists don't often always ask about these either. And even if they do, there's other issues in addition to that in terms of the timing of taking medications. Like, if you take, say, osimertinib, do you take it in the morning? Do you take it in the evening? And which medications are you taking along with that? That could also impact the metabolism of medications. And again, I think this is research that's very important. And I'm glad that he is looking at this because, this is something that could really impact how medications are working for our patients.
Yeah.
And I would just like to add to that too, not just how medications are working, but how we experience side effects. So that was something else that he had talked about, was the interaction and, the correlation with the side effects that people have. And side effects are a big deal because if, the less side effects, usually the longer people can tolerate being on the treatment. And so it's such an important area that hasn't been studied, probably because we're looking we've been looking at more treatments and better treatments, but it's definitely time to start looking at this now. And it's, his presentation was pretty interesting. It fascinated me.
It was great work, and I think that you probably found a room full of potential collaborators to move this project forward as well. Um, Continuing with the junior faculty presentations, Dr. Regan Mehmet from the Ohio State University presented an update on the phase 1b study of osimertinib and tegavivint as first-line therapy in patients with metastatic EGFR mutant non-small cell lung cancer, really bringing in the impact of the beta-catenin Wnt pathway on kinase inhibitor resistance. And this is a trial that's ongoing now, very impressive work that Dr. Mehmet is collaborating with colleagues at Ohio State, Dr. Dwight Owen, Dr. David Carbone, very expertly presented. And to close out our junior faculty, the final presentation was from Dr. Susan Scott at Johns Hopkins University, who looked at first-line osimertinib in uncommon EGFR mutations, including atypical exon 19 mutations. While there are some typical exon 19 deletions, there are others that are a little less common and compound mutations, really showing, I think, that not all of them behave equally. Some actually did not respond particularly well. It's important to know that, because maybe those are areas where we can explore alternate strategies, such as combination therapy up front. And so, again, a common theme that not all EGFR alterations are equal, and that granularity, those differences, we don't need to shy away from those. We need to lean into them and embrace them and really try to further personalize treatment. That really is how we're going to make progress. When we look at all these presentations, very impressive. There were a couple themes I thought that sort of came out. One was on resistance, and we saw a couple different mechanisms of resistance, targeting pathways of resistance. And Ivy, when we think of resistance as a general theme in treating EGFR mutant lung cancer, I think this is an area where we need more research, we need more funding. Do you agree?
Oh, definitely. I mean, we recognize that resistance is a huge issue for our members. I mean, pretty much everyone at some point experiences resistance. So, we have made an effort with our patient-driven research collaborations to fund and address areas of resistance. As a matter of fact, we just recently announced the projects, the research projects that we are funding in 2023, and both of them have to do with areas of resistance. So we are, we hear how important resistance is, and we are, addressing that as much as we can.
Another theme that came up a couple of times was ongoing and planned trials. Based on some case reports here and some early data, these trials are very promising, and based on some of the work that was presented, I suspect some of those will then lead to other trials. But Jill, it's hard for me to keep track of all of these trials. I can only imagine on the patient side, how do you even find out about all of these active studies? Are there any resources you might be able to recommend to some of the patients?
Yeah, it is getting more and more complex and complicated, with patients having different lines of therapy and various mutations, co-mutations, and it's overwhelming. So what a volunteer in our group has done, they put together a spreadsheet on the different clinical trials that we know of. And so I just want to point out that it might not be all of them, but we really try to dig deep and find the ones that we can. And so the trials are a spreadsheet. If you go on our Facebook page, you can find the spreadsheet, and most of the trials are post osimertinib right now. That could be changing if first-line therapy starts changing as well. but most of the trials right now are second line therapy and beyond. And really, they're broken down into the mutation and the resistance mechanism. And hopefully, in the near future, and I say we as a whole community, can figure out a better way for patients to type in a few things, a little bit of their information, and we can find trials that way. Because I do think that the clinicians also have a hard time finding these trials, especially if they're small. And so sometimes it's the patient who brings, hey, this trial is opening at this institution. I don't know if you've ever experienced that, but that's the beauty of our group and being able to provide the information.
I have experienced it. Always welcome. So, we definitely need help, and we shouldn't be afraid to ask for it. Keep track of all these things. This was a wonderful summit here in November, and we did have a very nice Research Summit Awards ceremony afterwards. If we look at the trainees, in third place, it was Dr. Marie Dreyer from Northwestern, looking at her phase 2 study of amivantamab in patients with metastatic non-small cell lung cancer with an EGFR fusion or a MET fusion. She received our third place for the trainees. Second place went to Dr. Kevin Levine, who looked at the EGFR kinase domain duplications. He's from the University of Washington Fred Hutchinson Cancer Center. And in first place for the trainees, again, we were very impressed by his work, Dr. Eric Gardner at Cornell on the role of RB1 loss in histologic transformation from adenocarcinoma to small cell. Ivy, I was, when we score these abstracts as judges, we look at the innovation, we look at the project itself, the methods, the science. We also look at how it was presented. I thought Dr. Gardner did a really great job presenting this work.
Yes, I agree. He really did. And one of the things that, the investigators also receive as a benefit of participating in this workshop is some coaching in presentation skills. Typically that's done a few days or a week or so prior to the workshop online, but it really helps them gain confidence and, learn how to present clearly and concisely, because in a lot of cases, again, these are, young investigators. They haven't had that many opportunities to present their work in front of, knowledge leaders in the field and patient advocates. So I believe that is helpful to them and really adds to the quality of their presentations as well.
I agree. What a wonderful bonus benefit. If we look at the junior faculty awards, the runner-up was Dr. Alvaro Quintanel Villalonga, who looked at RB pathway inactivation for transformation from adenocarcinoma to squamous cell carcinoma. He's doing work at Memorial Sloan Kettering. And our junior faculty distinguished winner was Dr. Benjamin Hertzberg from Columbia University, again, looking at ATR inhibition as a mechanism, as a means to target resistance, the process, rather than the end result in EGFR mutant non-small cell lung cancer. And Jill, I know that some of the investigators had talked to you, and while we look at the mentee, mentor, faculty, judge as maybe an intimidating panel, I think that some were also kind of intimidated by you and Ivy, right?
Yeah. Yeah. So interestingly enough, when we were sitting down after the award ceremony, talking to a couple of them, one of them said that was his biggest fear, was actually presenting in front of us because we are the patients. And so, I found that very interesting because as patient advocates, especially when we're starting out, we're intimidated by, the clinicians and the researchers because we don't speak the same language. So we just, told him that actually means you care, and we appreciate that. So it was, I do think that they get nervous now talking to patient advocates, and we need to do a really good job of encouraging them to report things accurately and at the same time help them understand language that's not only appropriate, but that's patient friendly. So they can, report things in a way that they understand in a safe way without criticizing or anything like that. But yeah, they are. So
It was a wonderful summit, and we get to hear this ongoing research. We get to have practice sort of interacting with colleagues, answering questions. We have these small groups where we can target some very important career development issues. We have coaching on how to speak, and in addition, you form these connections with the mentors and judges, but also amongst the investigators themselves. And often they'll go out afterwards and have dinner together and really bond together, making these important connections. And it's just going to
yeah.
make the field stronger and better. So congratulations to all the young investigators for wonderful work. This is a competitive summit, but they all that presented did a fabulous job. Congratulations to the winners, and congratulations to you too as well, Jill and Ivy, for another successful summit. Blown away at how impactful these are. And so thank you to both of you, and I'm going to throw it back to you.
Yeah, no, thank you. I would say to sum up kind of what we're saying, first of all, this summit has a significant impact on advancing the professional development of this next generation of lung cancer researchers through the people they're meeting and the work they do, but also, as I think Ivy mentioned before, it's designed to be an intimate setting where they can have all these different opportunities to interact with each other, to witness, the passion and excitement of that is truly inspiring for us. And I think their eagerness to network, to discuss their work, to talk about collaborative efforts moving forward, and to feel more comfortable as the day went on is a testament to why these small, intimate summits are important. And, it filled my heart with gratitude, as I'm sure Ivy and Diane's. But also want to recognize the unwavering support from all the mentors, judges like you, Stephen, to support the young investigators like this. You guys were all very genuine, and you created a safe space for them to present their work. And I think that that's huge in helping them in their career evolve. I think that having the intimate setting with the small group discussions, that really allowed them to create these personal connections that will help with their career as well. Some of the conversations were really interesting and got really deep, and they needed guidance on things they don't learn in medical school, and they don't learn necessarily in when they're trainees, such as working with advocates, or how to talk to patients about certain things. So we are so grateful for our mentor judges and their unwavering support for our community, always stepping up to help in any way that you can. We really appreciate that. Thank you. We are grateful for the AstraZeneca for their continued support of this event, and we wouldn't be able to do it without them. And of course, CC Oncology, your tireless efforts, your creativity, your patience with us, and the amount of energy that you put into making this a successful event is nothing short of amazing. And we thank you from the bottom of our hearts.